Hi. Thank you very much. It's wonderful to be back, and thanks, Dr. Bhati, for this wonderful course and inviting me to speak on it. So you've heard a very interesting introduction to this course and how Dr. Bhati has elaborated on the importance of corneal thickness and how much of residual corneal thickness to leave behind when we perform refractive procedures. The question is why these controversies? And these controversies have essentially arisen because topography and thickness are the only two parameters that we have really considered. What we have always omitted is to see what we call the material characteristics of the tissue. And that's the material characteristic that is what I'm going to talk about in this talk on biomechanics. Now, biomechanics has over the last about 15 or 20 years really come more in front, largely on account of studies related to facility of outflow and glaucoma rather than refractive screening. But it has been applied now to refractive screening as well. So I'm going to talk about the importance of corneal biomechanical analysis, and I've been doing this since 2005 when I got my Aura machine. I have no proprietary or financial interest in any of the products. Now, Dr. Bhati has already defined what keratoectasia is, but essentially it's an anterior shift of the cornea with inferior and central steepening. It's got a worsening myopic astigmatism, irregularity, and there are a decrease in the BCVA because of visual symptoms. Just a brief idea of the incidence. If we look at the earlier cases, there were very few refractive surgeries being done worldwide, and so the number of cases reported were not that many. The incidence was 0.66 in Palikaris's study, and later in a study published in 2021, where they did a meta-analysis of many of these articles, they found the following incidences which are largely representative of these procedures, and this includes SMILE. And so you can see that there are about 0.02% is the incidence in PRK. It's about 4.5 times higher in LASIK, and it's 0.01% in SMILE. Still early days because SMILE still hasn't caught on, and we need many, many more numbers to be done worldwide before some real data can come out. So we were talking about the causes, and Dr. Bhati was elaborating on some of these, but largely it's a residual stromal bed following surgery that is thinner than what's expected. And this is either due to an unpredictably thick corneal flap, which can be either mechanical tissue loss, or it's a preoperative pre-existing anomaly or measurement error that may have happened. And these undetected topographic abnormalities can sometimes contribute to the fact that you missed an ectasia. It's the biomechanical properties that I'm going to speak of that is largely the so-called missing link or the X factor, which we have not taken into consideration over these years. And I think as it becomes the mainstay in refractive procedures, we're going to be having much less of ectatic problems. So the concept is that there's a focal weakening in the corneal structure, which starts a chronic cycle of biomechanical decompensation leading to a localized thinning and steepening. And in LASIK, it's a two-hit hypothesis. And this proposes an underlying genetic predisposition coupled with external or environmental factors. And here the external environmental factor is actually the thinning that we have now induced by the LASIK. And it's the changes in curvature, elevation, and thickness that occur due to these secondary events makes the primary abnormality related to the direct biomechanical weakening in the corneal stroma much worse. So the ectasia development occurs due to a chronic corneal biomechanical decompensation of the weakness, and this results in the stromal thinning and corneal protrusion. So 3D tomography has been a significant advancement as compared to the older keratographic or Placido-based technologies. But these screening tests for ectasia have always been limited to corneal shape assessment without really looking at clinical biomechanical assessment, which has only been possible since these machines have now come out. So in the preoperative evaluation, it's important to detect the high-risk individuals who may experience corneal ectasia after LASIK from the patients who can undergo the procedure safely, because this complication can occur in patients with or without any pre-existing clinical evidence of formiferous thick keratoconus. So we do need to understand very basically what biomechanics is. And if you can imagine a shock absorber, and in a shock absorber in a car, there are two components to how the shock is absorbed in the car. There is a spring, and there is a canister which contains a fluid or a gas. And it is the combination of these two that gives us the protection. So the cornea pretty much follows a viscoelastic pattern, and it reacts to strain, or when there is deformation and there is a force that is applied, the amount of bend or compression that you will get in a tissue in the coil spring part of this shock absorber is independent of the length of time for which you apply it, or the rate at which the force is applied. So if you compress a spring, it doesn't matter how quickly you compress it, and it doesn't matter for how long you compress it. When you release it, it's going to come back. However, the shock absorbing or the viscous damping effect is completely different. The faster you apply the force, the more viscosity is going to resist that happening. And this resistance depends on the speed at which the force is applied. And it's a combination of this that provides the cornea its unique viscoelastic properties. So Goldman tonometers, essentially, are tonometers that reach a static state. So they compress the cornea till you get applanation. And in that static state, they take certain readings. Whereas these newer instruments actually look at the dynamism of that movement. So when they actually hit the cornea, they actually see the cornea going in, they reach flattening, but they don't stop. They continue till the cornea becomes concave, and then they stop so that the cornea becomes again flat, and then again returns to its original convexity. And in fact, this process of rapid dynamic movement creates a little bit of a flutter, which it also picks up. And then it uses all this data to tell us about corneal biomechanics. And it is this dynamic measurement that allows the possibility of capturing useful biomechanical data. Now, thickness-based assessments, which is what we were talking about a little earlier with PTA and all that, is that thickness is not resistance. So if one has to look at the strength, one has to look at the material characteristics. So you have a 2 millimeter thick piece of pine wood, and you can bend it. And if you have a 2 millimeter thick piece of oak wood, you can't bend it, but it's 2 millimeters. So the point is, when a force deforms these tissues, how much actual deformation do you get? And that's biomechanics. It's virtually impossible to actually check biomechanics in vivo. In vitro, it's possible. You can take tissues and do, Young's elastic modulus and all that. But in vivo, it's very, very difficult. So refractive surgeons have tried to minimize the potential for ectasia by essentially leaving a minimal thickness of cornea in place, which is good for the large part and on average, but is not entirely satisfactory because biomechanical properties of the corneal tissue for each patient are unknown, and thickness is not strength. So there may be soft corneas, which may require a larger residual corneal thickness than normal corneas, and there may be hard corneas, which may be able to tolerate more aggressive ablations safely. And I recall a patient that I did, he had 22 diopters of myopia. And I told him, you'll have some residual myopia left, and I did 18 diopters of ablation. This is going back to 1995, I think it was when we started. Patient's fine. He's got 180 microns of residual corneal bed, which in today's day and age would be criminal. So at time when there were no guidelines, there were no biomechanics, we only had corneal topographies, LASIK had come in, and this is how it was being done. So even though we reduced the zone size and did everything else to try and reduce the amount of ablation, that is a matter of fact. And I'm sure people who started LASIK going back into the mid-90s will all have anecdotal experiences of patients who we did with high double digits of myopia ablations and got away with it. Luck. So here's the scene. So you look at the pre-LASIK and the post-LASIK scenario of what we call CH. CH is corneal hysteresis, and I'll just talk about it in a minute. And you'll see this average pre-op band of LASIK on the top there, and in the blue dots are all these post-op LASIK bands. So you know you've created thinning. So when you create thinning, you will lead to some loss in resistance. But you notice this one patient whose pre-LASIK CH is lower than the population average post-LASIK CH. This is the one you need to worry about because he's the one who's going to get ectatic. So, like I was saying, if you look at the map at the bottom, you can see that the air puff is hitting the cornea, and then there is a state of applanation, and then there's a state of corneal concavity, and then there's a state of applanation as the air puff goes away. And again, the patient comes back to its normal convexity, and this is what happens to the signal peak. So you get a signal peak when the applanation happens going in 1, which is applanation 1, and then when there's the out signal, when the applanation again happens, that is called the out signal or applanation pressure 2, and it's always different. And the difference between applanation going in and applanation coming out is what we call the corneal hysteresis. And this is critical to our approach. So in a normal patient, this is the ORA, of course, you will find that you have these two peaks which are very similar. You have the two pressures which are very similar. There is a good match between the signal quality and the signal amplitude as well. And the raw signal is fairly smooth. The baseline signal is flat and nearly the same amplitude on both sides. However, as one gets into keratoconus, you can find that the amplitude has got blunted. There are now these little spikes that have come. There is a raw signal that has become much more bouncy and become noisy as well. So these are indicators of a flutter, if you understand what I mean. If you have a keratoconic cornea, if you're familiar with keratoconus and keratoconus cornea, they're relatively softer and they're floppy. So you imagine hitting it with an air puff. It's going to do this. And that's what this machine picks up. So these noisy signals, of course, cause less reliability. Now in subclinical keratoconus, again, you find this odd looking lower amplitude peaks with a bounce and with IOP-CC higher than the IOP-G and noisier signals, but cleaner than the advanced keratoconus and more repeatable. Now you see the severe keratoconus signal. The severe keratoconus signal means that this patient just applanates the moment the air puff hits it, because there is hardly any resistance in this cornea and there is hardly any spike that one can see at all. So this is all indicators of very, very poor signal amplitude. And here there is, don't look at those values in the box, because with this kind of a signal, there is no question that this is keratoconus. In ectasia, again, these signals will match those of keratoconus with a lot of bounce, very low amplitudes and messy signals. And these signatures of the cornea are like diagnostic signatures at least with this machine. We can use these classification of corneal pathologies as well. So if one looks at thickness and one looks at, say, a normal population, which is there in brown, you can see their corneal hysteresis values. You see the keratoconus, they are all thin corneas. They are skewed to the left. So they have poor corneal hysteresis, but these are thin corneas. On the other hand, look at Fuchs dystrophies. Fuchs dystrophies are all thick corneas. They have 550, 600, 650 corneas, but they still have a low hysteresis. So if you just measure the thickness with a pachymeter or with any other device, you can say, this patient has a 600 cornea. He may actually be having a little bit of endothelial dysfunction, but you put him on the hysteresis value on the machine, and you'll come up with a value of 6.5 or 7. And that will tell you that this thickness is not genuine. So these are the other values that it comes in. It gives you a keratoconus match index, where again it uses this signal profile to tell us that there's an 89% chance that this is a normal cornea. This one has a 55% chance that it's a suspect, and only a 34% chance that this is a normal cornea. And some case reports from my own experience where there's patients with fairly normal looking Ks, a little bit touching just 47. Cornea thickness was a little on the lower side, but terrible hysteresis and corneal resistance factors, and the KMIs were all in the 0.5 range, an absolute no-no to do any form of refractive procedure. Patient number 2, nothing unusual on the Ks. The Pathfinder topography was also normal, very good corneal thicknesses. Look at that, 550 almost. But look at these CH values, again 9.8, 7.5. So this is a subclinical keratoconus that if you ablate, you're bound to get into trouble. This is the newest device. The Aura, as it existed, is now no longer in the market. They have gone off into glaucoma as their main area, and they're not doing as much of refractive work anymore. But the Corvus ST has very nicely plugged in the gap. It uses a Scheimpflug camera to detect the deformation created by the air puff, and it measures the IOP, the corneal thickness, and the deformation response, and then determines the IOP, which is uninfluenced by any biomechanical property by using the algorithms. It's also very useful for screening for corneal ectasia. And now the manufacturers have clubbed this with the pentacam to create a new set of indices, which I'm just going to talk about. So the Corvus ST creates a biomechanically corrected IOP. So it gives you, just like the Aura, it gives you an IOP that would match with the Goldman value, in which it is not looking at corneal thickness or biomechanical abnormalities. The Goldman doesn't know whether this cornea is abnormal or not. It will just take a value based on the spring force and give you a number. But this machine is smarter. So it will tell you that value also, and it will give you a value which it compensates for the corneal biomechanical change. So this is called the biomechanically corrected IOP. In the case of the Aura, they call it IOP-CC. CC stands for compensated for cornea. And then there's the Corvus biomechanical index, where again it uses the same data to assess what the biomechanics of that cornea are. And then it combines this with the pentacam values. So now you have topography and Scheimpflug of the anterior and the posterior float. You have the Bellin-Ambrosio display, and you have biomechanics fed into one system. And they have combined these two to give you by far the best aspect as far as screening for these patients are concerned. So here's a patient. I don't have a Corvus ST, so I am thankful to Dr. Hemlata of the Center for Sight for providing me this. So this is a patient with a 5.5 diopters of myopia. Normal case, corneal thickness is on the lower side, but it's still around 500. The initial plan was to do a FEM to LASIK, but then you look at this value here at the bottom, what we call the TBI, or the tomographic biomechanical index, and you find it is very high. If you look at the Bellin-Ambrosio display by itself, it's not that bad. Both the CTSP and the PTI changes are not outside the range. If one looks at purely biomechanical factors, again, they are not outside range. But when you put them together, you find that you have a patient who would not be a good candidate. So that was converted from a flap-based procedure to a surface ablation. The patient was very, very keen, and coupled with what we call a CXLs to help protect the, prevent the ectasia. So, to summarize, mild ectatic cases typically are at very high risk for iatrogenic progressive ectasia if an additional biomechanical weakening is induced. Corneal topography and tomography have increased their ability to identify these ectatic candidates earlier. Direct clinical biochemical measurement is recognized as paramount for augmenting the specificity and sensitivity for identifying these cases with mild disease and for characterizing the susceptibility for ectasia progression. So corneal biomechanics testing with the availability of these newer equipments allow in vivo measurements of corneal biomechanics and is becoming a key evaluation in ectasia detection and filling the missing link in our screening for high-risk refractive surgery cases. So thank you very much, and be very happy to take any questions.